Okay. So, hi everyone. My name is Cody Liddell. So, I'm the clinical pharmacy manager for our ambulatory care pharmacists here in the Central Arkansas area. I just recently moved into this role in June of last year. And so many of you may be familiar with me from my previous role. Prior to this, I was the clinical pharmacist for the UAMS Northeast Regional Campus in the Jonesboro area for several years. Today, I really would like to talk to you about continuous glucose monitoring for primary care. So getting beyond A1C, I think we'll continue to use a combination of both over the next few years, but we're definitely seeing a rise in continuous glucose monitoring. And so we want to be able to kind of meet our patients at that level, especially as they, I think, see more exposure to that, whether that be, through television, as with older kind of drug commercials, but also through social media, Facebook, even TikTok, YouTube, things like that. So getting that exposure, because you'll definitely see that, I think, as time continues to move on. I have no financial conflicts of interest to disclose, kind of getting that housekeeping out of the way. I'll briefly discuss my objectives for the day. So today, the plan is to aid in identifying commonly utilized continuous glucose monitoring systems and develop awareness regarding prescribing practices and education regarding these systems, compare common insurance and payer requirements, and develop necessary documentation skills and habits, apply skills in continuous glucose monitoring data download, report, and interpretation, develop patient-specific treatment and monitoring plans in response to continuous glucose monitoring reports, and discuss coding and reimbursement for continuous glucose monitoring in the primary care setting. So before we dive in, I do want to clarify this presentation is not intended to be comprehensive or all-encompassing. So there's no possible way that I could cover every piece of information about CGMs or even everything you might want to know about them in a single-hour presentation. Today, we're really going to focus on real-world knowledge and clinical pearls for the implementation of CGMs in your practice, both here in the UAMS system and beyond for you residents that'll be graduating over the course of the next 3 years. So it's important to note that both guidelines and insurance thresholds to obtain CGMs for our patients have continued to evolve, with Arkansas Medicaid having instituted large changes in January of 2022. Prior to that, it was very difficult to get CGMs, for those patients. And CMS just implemented a major change as of April 16th, so literally just last month, which we'll get to shortly. So more and more of your patients will be showing up with these in your clinic, as I've just stated on the last slide. And they're going to be asking questions about them. So knowledge is accessible now more than ever. And so I want to be able to equip everyone in the primary care setting with applicable clinical knowledge, prescribing and documentation resources, and resources within both the UAMS system and the healthcare community. So I strongly believe in the importance of the involvement of primary care in the care of patients with diabetes, as I just mentioned, and with continuous glucose monitoring on the rise. I think knowledge about this is very important, both for, here at the UAMS system. I think a lot of times we may refer to other people within the system, but especially if you go into rural health, you may not have that option. And so enabling you to manage that within your system. So a recent survey from 2018 of 209 diabetes providers from the ADCES found that only only 20% of clinicians said that they were ready to promote CGM adoption fully in their clinic, and that 39% of providers found that they were not yet ready to promote that within their system. And an additional 20% said that they were cautious and stated that they could adopt that within their clinic. There were several contributing reasons, with some of the largest being educational, workflow, and limited clinic time. They weren't really sure how they could fit that into their practice. And so it really motivated me to want to address this on a system level and to give you those skills to incorporate that both here and beyond. So moving into the meat of the material, I'd like to start with a big picture overview of glucose monitoring. And I think that's an important step back and recognize the role of this in therapy. So why do we monitor? So for one, as clinicians, we need to we need the information to track a patient's therapy. So we need to find out if the form of therapy they're utilizing is working effectively. If not, where are the troublesome spots so we can help them resolve it. Also, A1C does have pitfalls. We can be operating between the extremes. And so my residents in Jonesboro definitely heard me talk about the law of the averages many times. So you may get an A1C of 6.8, but your patient could be having extreme hyper and hypoglycemia. And so you need to, you wouldn't necessarily see that unless you had their blood glucose levels. A1Cs can also have errors in the cases of chronic disease and anemia. And so this is where these values come in handy. We can also utilize blood glucose monitoring in point in time decisions. So patients may be making mealtime decisions and sliding scales. This also lends to helping them understand causal relationships over time. So how do their choices, behaviors, snack and mealtime intake, medications, et cetera, affect their blood sugar and ultimately their A1C and overall health long-term. As well as ensuring their safety. So hypoglycemia is dangerous, of course, but also for patients with hyperglycemia. Patients with very high glucose can become very drowsy and not think clearly. So this could be dangerous for any patients that have to, maybe drive frequently or operate heavy machinery. I've definitely seen that happen. Also for more severe risks of DKA, HHS, things of that nature. So what do the guidelines say about continuous glucose monitoring? So people who are on insulin should be encouraged to check their blood glucose levels when appropriate based on their insulin therapy. And I've highlighted that this may include checking when fasting, prior to meals and snacks, after meals, at bedtime, prior to exercise, when hypoglycemia is suspected, after treating low blood glucose levels, until they are normoglycemic. So it's not just once. So when hyperglycemia is suspected, and prior to and while performing critical tasks such as driving, as we just mentioned. So this is a lot of times per day to potentially check your blood glucose. And patients get very burnt out on this. And you'll see that in clinic, especially after they've been doing it long term, or they may get very motivated to do it in short-term periods, but that may fall off. Or even if they stay motivated, I have patients that, their fingers just get very worn out and they get very tired of doing this. And so it can be a very large burden on them, even if they do stick with the treatment plan. So moving into what do the guidelines say about continuous glucose monitoring? So continuous glucose monitoring should be offered for for diabetes management in adults with diabetes on multiple daily injections or continuous subcutaneous insulin infusion. But they also have one that just says it should be offered for patients on basal insulin who are capable of using the devices safely. So it's not just for patients on multiple daily injections anymore. It can be offered to patients who are on just basal insulin, because patients who are on basal insulin are also testing more than just your basic patient that is on maybe just oral medications. And so I think that's something that should be considered at baseline. So moving on to continuous glucose monitoring, let's talk about some of the devices and features. So what are the components of a CGM system? So every system has three components in common. So there's a glucose sensor that's inserted just below the skin. That sensor is typically made of a metallic filament that has an enzyme embedded in it. You'll be surprised at how many patients think that there's a needle that stays under their skin. So it's important to clarify that. The enzyme reacts with glucose in the interstitial fluid. And it's important that is different than blood glucose monitoring. And we'll talk about why that difference is important here in just a second. The sensor does not sit in a blood vessel and it's not measuring glucose directly, but indirectly once it appears in the fluid below the skin surface. So when that enzyme reacts with the glucose, it generates a tiny electric current. And so there's a transmitter attached to that sensor, which detects that current and sends a signal to a display or a receiver. That interprets the signal and generates data for the user. So that display receiver can take a variety of forms, as many of you know. And so you'll see some patients that utilize their phone for that. You'll see some patients that utilize a separate reader for that. And some that can even utilize their smartwatch for that. So you'll see people use Apple Watches and other forms of watches for that as well. So we have multiple different, I would say, modalities that patients can receive this information and then upload that to their healthcare provider. So it's important to kind of know these parts. Now, sometimes the sensor and the transmitter can be combined into a single unit. You'll see that with your Freestyle Libres and your newest Dexcom system, and we'll kind of compare those devices here in a minute. So like I said before, remember CGM occurs near a blood vessel. It does not occur in a blood vessel. So capillary glucose must diffuse into the interstitial fluid. This leads to what is called lag time. So interstitial fluid glucose levels lag capillary levels by 3 to 5 minutes. Longer lag with decreased, you'll have a longer lag with decreased subcutaneous blood flow. So things like exercise and stress. And so if glucose is rising, especially if it is rising quickly, your CGM is likely lower than actual blood glucose. If CGM is falling, especially if it is falling very quickly, your CGM is likely higher than your actual blood glucose. When your CGM is stable, lag should be almost non-existent at that point. Your real life implication with that would be when your patient is doing a sliding scale or they're doing mealtime doses, they could over or underdose their medication. Your other large implication for that would be when they're setting alerts. You may want to set the alerts for, your upper end or your lower end slightly higher or slightly lower than what you would normally think you would want them to set, just so you capture it before you get to that point because of that lag time between when they would actually get to that level. You want them to be alert on the way to that number, especially if they're rising or falling quickly, which the CGM will alert them to with specific arrows. And so that could be really important when you're setting those alerts. Okay, so moving into kind of the benefits of CGM. So decreased discomfort and hassle. So like we talked about, they don't have to poke their finger constantly. They can place that CGM on their arm or on their abdomen, depending on the device. And really, once they place it, it's there. Now, obviously, some patients do have, I would say, issues with the device coming off. And most devices do have, I would say, tips or tricks or ways to kind of keep those on more. And that's definitely counseling you can provide or refer them to your like a pharmacist in clinic or to the website or to the rep to kind of help or give them resources. I think we have a lot better resources for that now than we did 5 years ago. And so that's definitely something we can troubleshoot with patients if your patients have had issues with that in the past. Also, they have safety alerts. So your blood glucose monitor, where you're just checking 1 to 2 times, maybe up to 4 times a day, is not going to alert them before the low or the high happens. They know because of how they feel in their body. And whereas the device itself is going to warn them based off of the actual reading. And so they don't have to wait until they feel bad or until they're experiencing symptoms. This is especially important in patients that have hypoglycemic unawareness. And so if they don't experience those symptoms anymore, which can be very dangerous. So diabetes technology integration. So if they have a pump, it can integrate with the pump. If they have those smart insulin pens that can kind of dose themselves, they can integrate with those pens. Data analysis and reporting. So you get a wealth of data. Some would probably say too much data, but it's very important, I think, when making those treatment decisions, especially as maybe we get away from A1C and to seeing some of the long-term benefits of looking at time in range. So there's also convenience. And so patients can look at their phones, or they don't have to remember to check, their blood sugar. Or if they're in public, it's not as embarrassing, maybe for them to have to check their blood sugar or to take as many steps, to do so. And so there's a lot of things like that for patients that it really integrates into their life better. And so it's really about quality of life, I would say, more than it is convenience. There are pitfalls of CGM. So we just talked about lag time and accuracy in the moment. And the other big one is cost and accessibility. Even if it is improving, we do have patients that still have very large copays or that it's not covered at all. And so that can be very frustrating when they know this technology exists, but they just may not have access to it. And that can be very difficult for them to see. So types of continuous glucose monitoring devices. There are several, and some of you may have heard these definitions, some of you may have not. So RT-CGM is going to be that real-time CGM. So these are CGM systems that measure and display glucose levels continuously. So what that means is that it transmits automatically to the reader or to your smartphone. You don't actually have to scan the reader, or excuse me, the transmitter itself. Intermittently scanned CGM is something that measures glucose levels continuously, but you have to scan it for visualization and storage of that data. And we'll compare and contrast different systems here in a minute to kind of show you what I mean by that. Then you have professional CGMs. So see, these are CGM devices that are placed on the person with diabetes in the healthcare professional's office or with remote instruction and worn for a discrete period of time. So it's typically going to be about 7 to 14 days. I typically see them for 14 days when they're done. And data may be blinded or visible to the patient wearing the device. The data are used to assess glycemic patterns and trends. And so these are clinic-based and not owned by the patient. So typically, to give you, I would say, a more real-world look at that, your office would buy those CGMs and keep them in-house. You would have the reader. I typically see them in a more blinded fashion, so the patient does not have a reader. And what you do is on day one or day zero, the patient would come in and get that device placed on them. You would do counseling, talk to them about what you're doing, and they would come back 7 days later. After 7 days, you look at what they've done. Typically, they've made no changes, just lived their life and done what they normally do to manage their diabetes. And then you show them what the trends look like, and you work through that with them. And then you make changes at 7 days and then have them back 7 days later. So at day 14. And then you compare that and show them kind of what changes in response to that. And you show them how those changes directly affected their glucose patterns, because you'll have two directly comparable 7-day periods to compare to. The benefits of professional CGM are that sometimes Medicare plans will cover them better than just personal CGMs, but you can't do them continuously. So it's not like you can do 14 days and then turn around and put another professional CGM on. So there are pitfalls to that as well. But sometimes if you need maybe bursts of professional CGM data with patients, you can do them a couple of times a year to kind of help make those, I would say, tweaks in patient therapy to really optimize patient care in specific patients. I definitely think there are benefits, there are pros and cons to each type of CGM. So we're going to look a little bit at our most commonly used CGM systems. So your Freestyle Libre systems, which are probably the ones that most people see, I would say, most frequently in primary care. There are 3 systems that I would say you'll still see floating around at the moment. These were not the first Freestyle Libre systems or the only ones that are in existence, just the ones that are still, I would say, orderable or still available. Or that you'll still see patients using. So you've got your Freestyle Libre 14-day. So this is the first one that had switched to being available where the sensors were 14-day. Before this, the sensors were 10-day sensors. And so you could use either the smartphone app or you could use the reader for it. Then you have your Freestyle Libre 2, which also has a smartphone app and a reader available. Then you have your Freestyle Libre 3, which is the newest one available. It, until recently, did not have a reader, but the reader was just approved by the FDA last month in April. And so there are, even though they look very similar, I would say differences amongst the 3 of these devices, and we'll talk about those here in just a second. Then you have your Dexcom systems, and Dexcom G6 is the one that I would say most of your patients are still on of the Dexcom systems. If they are on one, Dexcom G7 is their newest system, and it does have some differences from the Dexcom G6. It's not just, newer and prettier, and it became available within the last year as well, and it is very new. So to go through a table and kind of compare these, I know there's a lot of data on this, and I'll try to highlight, I would say, the most important. None of these require calibration, and that is why they're so easy to use for our patients. So calibration would mean that you would have to do a blood glucose check to make sure that it is working correctly, or to line up the readings. Sensor wear, so the Freestyle Libres are 14 days per sensor, and Dexcoms at this time are 10 days. I believe there is a plan for the G7 to switch to a longer wear sensor of 14 days. But it has not done so yet. your warm-up period. So that is how long it takes to pair to the reader or to the smartphone. With Freestyle Libre, it is a 1 hour pairing. With Dexcom G6, it's 2, and G7, it is a 30-minute pairing. The Freestyle Libres, it is a combined, which is the last line there, that integrated sensor and transmitter system. Whereas the G6 was a separate one. So if we go back to the previous slide, you'll see here that you had to do like an applicator, and then you had for that sensor, and then you had to put the transmitter into it. So this is the part that applied the part that went under your skin, and then you had to pop that transmitter into the top of it, and you had to change that part out and then re-put the transmitter into it. But then every other system that we're talking about is an integrated system, which is a change for the G7 in this line. Your Freestyle Libres were that intermittent CGM that we were talking about. So there are definite pitfalls to that. If you look at that concerns for data loss, you had to scan your Freestyle Libre 14-day and your Freestyle Libre 2 every 8 hours. And we'll look at some reports in a minute at what that can do, especially when patient care kind of is on the line. If patients forget to scan that, you do lose data. With your newer systems, you're not really concerned about losing data unless you kind of get out of range. And so Freestyle Libre 3s do have a range of 33 feet, which is how far they can be from their reader. And then Dexcoms have a range of 20 feet. Frequency of measurement, your Freestyles do check every minute, and then your Dexcoms are every 5 minutes. The real benefit of Dexcoms and over Freestyle Libres, I would say, are that insulin pump integration and that diabetes technology integration, which is not yet available with your newer Freestyle Libre devices. And so you will see that really frequently in your type 1 patients, because you'll see them, I think, with Omnipod and Tandem pumps, and you will see that used very frequently. And so I will say you are seeing Dexcoms begin to pick up traction, even in our type 2s as they become covered better. But our Freestyle Libres are cheaper devices. And so it's easier to kind of get those covered and because they have cheaper copays. So it's not that the Dexcoms won't be covered maybe in our Medicare patients, but if your patient has a 20% coinsurance and they have to then cover the 20%, the Freestyle Libre is a lot cheaper than the Dexcom. And so it's a lot easier for them to pick up that copay. With the mobile apps, it's really important, especially with your Android patients, to really think about compatibility with their phones. So these are all compatible with iPhone, but once you get to Android, they are compatible with Android, but there's a large asterisk there. So knowing which Android phones these are compatible for, because the Dexcom Clarity app may be compatible, especially if you're looking at your Dexcom G6, but the Dexcom G6 mobile app may not be. And to sync that data, both have to download. And so with your others, you may only have to look and see that one app is compatible. So with your Freestyle Libre 2, your Freestyle Libre 3, your Dexcom G7, but on your G6, that has been a major pitfall that we've run into in clinic. I ran into 3 patients in clinic just last week where that was a problem, where they thought their Samsung phone was compatible, but it turned out to not be compatible because it was only compatible with the Clarity app. And one patient had just bought a brand new phone because she thought that phone was compatible. And so she was pretty upset at that time. And so we had to order a new reader for her just so she could be able to see her data in real time. And it was a pretty frustrating scenario for her. And so you want to make sure that you kind of counsel them appropriately on that and what that looks like. So other systems, other personal CGM systems are available. There are several others, but I would say they're uncommon in our area and amongst this patient population for various reasons or requirements. They either, require calibration, or I would say they're more common with pumps or other diabetes technologies. The Freestyle Libre and the Dexcom are going to be, I would say, what is most common in our area. And then, as we talked about before, the professional CGMs are available, but require office ordering and setup, as well as trained staff and different documentation and billing requirements. And so you really have to have the staff, I would say, that is there to support that role and support that kind of workflow in your clinic to be able to do that. Another important, just I would say, educational and counseling point that I think frequently gets overlooked or ignored are interacting medications and substances. Now, this is a small list for, I think, CGM devices, but still an important one. So both ascorbic acid for Freestyle Libre and then acetaminophen at high doses, I will say, above what you would normally expect, and then hydroxyurea. So these can cause higher sensor readings than the actual glucose, excuse me. So I just wanted to kind of bring this to light, especially with that ascorbic acid with the Freestyle Libre. I would say that's the one you're going to see most frequently, but just so that you're aware that interfering substances can exist. And if they end up on a different CGM device, there are individual substances per CGM device because it depends on that enzyme and how it interacts with each specific device. And with blood glucose monitoring in general, that is also the case with glucometers. So ascorbic acid is a pretty common interfering one with glucometers as well. So moving on to patient access and real world application, which I'm sure you're probably most interested in. So barriers to CGM access. I'm sure you're aware of most of these. So variability of insurance requirements and formularies, prior authorizations. So this would include both the fatigue and the difficulty that comes with filling these out. I know they can be very confusing, and some insurances just cause problems. And sometimes it's the durable medical equipment company itself and not the insurance. And so kind of crossing that barrier. Additionally, secondary to that, there's a level of confusion of not only if the CGM will be covered, but where and how it is covered. So like I just mentioned, if it's going to be covered through their durable medical equipment or pharmacy benefits. And then if it's not covered, if the patient can't afford it, cost is going to be the issue. And then if it is covered, they may just have a very high copay, and that may not be a feasible option. So I can't fix all of these issues, but let's spend a few minutes digging into payer guidance. Medicare especially has made some recent changes broadening access. So first, we're going to go into typical Medicare, Medicaid candidates for CGM. So first, does the patient have Medicare or Medicaid? If they have Medicare, is the patient insulin treated? If yes, then they are eligible for CGM now. And this is a major departure from previous guidelines, which required them be on 3 or more insulin injections per day and be using their blood sugar readings to adjust their insulin throughout the day. And so on April 16th last month, that changed that. So they just have to be on insulin and they will qualify for a CGM. The other qualification that will get them a CGM, so if they're not on insulin, or if they are, does patient have a history of problematic hypoglycemia? If yes, they would also be eligible for a CGM. If no, they would not. So these are our two quality, I would say, factors that will qualify them for a CGM. So are they on insulin, and do they have a history of problematic hypoglycemia? And we'll get into the definitions of that here in just a second. So if the patient has Medicaid, it's a little different. They used to line up, I would say, a little better until Medicare recently changed its guidance. So does patient have hypoglycemia? And that would follow a similar pathway. And then if not, are they using insulin 3 or more times per day or using an insulin pump? If they are using an insulin pump or using 3 or more insulin injections per day, they would qualify for CGM. If not, they would not be eligible. And so really going down either pathway, is the patient insulin treated? If yes, CGM. If no, do they have hypoglycemia, which we'll get into? And then it would be the same thing on the Medicaid side, but they have to be using 3 or more injections per day. So classifications of hypoglycemia. Let's pause here before we get into what the definition of problematic is and just talk about general classifications of hypoglycemia, because I don't think this really gets defined very frequently. So level 1 hypoglycemia is a blood glucose less than 70 and greater than or equal to 54. Level 2 hypoglycemia is a blood glucose less than 54. And level 3 is a severe event categorized by altered mental and or physical status requiring assistance for treatment of hypoglycemia. And so you'll see these in the guidelines, but it's not something we talk about in our notes or in clinic very frequently. When I counsel patients, the only time I really make a delineation is to kind of tell them how much to treat. So when you're treating hypoglycemia, when they're kind of in that 55 to 70 range, I'll tell them, we'll go through what we kind of colloquially talk about as the rule of 15. So telling them to take, 15 grams of carbs, which you'll talk about as, 8 ounces of milk, or telling them to take, 4 ounces of juice, so half a cup of juice, and making sure that they get those quick sugars. So making sure that they're not eating something that's not going to absorb quickly, or something that's going to take a long time, like a peanut butter sandwich or something like that, during that time when they really need a quick sugar. And so then telling them to take more if their blood sugar is lower, or making sure that they have help if they're experiencing those symptoms. And so I may not necessarily refer to it as level 1, 2, or 3 with my patients, but that's kind of how I use these numbers to define how much they need to treat by. So if we need to increase the amount of sugar that they use to treat, or to discuss severity, especially in notes. So that's where that problematic hypoglycemia comes in. So what Medicare defines as problematic would be recurrent level 2 hypoglycemic events. So that's those that persist despite multiple attempts to adjust medication and or modify the treatment plan, or any history of a level 1, of one level 3 hypoglycemic event. So if they have any sort of altered mental and or physical status and require third-party assistance for the treatment of hypoglycemia. So if they have either one of these, you would just want to make sure you document that clearly in the note, and make sure that you talk about, if they've had multiple nocturnal hypoglycemic events, or what kind of barriers that puts before the patient, if they, a family member has had to help them, if they've required like an ambulance to come get them, or if they've had to go to the ER. I do have a patient that I had to get a CGM because of hypoglycemic events prior to I would say, the change in Medicare rules. So it was a couple of years ago, back when hypoglycemia was still a rule, but maybe not 3 or more injections with frequent changes. And there was a week where she had, multiple hospitalizations for hypoglycemia, just because she was having, I would say, severe issues with her response to insulin. And so you have to make sure that we quickly understood, I think, what the problem was once she got the CGM. There was, I would say, a level of understanding issue, but you just have to make sure that you document it very clearly in the medical record, because even though you think you've got it documented maybe throughout multiple notes, if you can congregate that all in one spot, it's going to be very helpful. Medicaid's hypoglycemia, the way that they have it documented is evidence of level 2 or level 3 hypoglycemia. So you do want to document it, but it doesn't, as far as I'm aware, it does not have the same, I would say, rigorous definition that Medicare does. So private payers and commercial insurance, I will say coverage is variable. It's typically covered with insulin administration, similar to Medicare and Medicaid, but every payer is going to be different and have different regulations. They're not regulated by the same governing bodies. And you may be able to obtain it at a pharmacy rather than a durable medical equipment supplier. However, I will say the DME companies that we work with, especially if you find one in your community that you go to that works closely with you, are very good, I think, at walking us through the process or getting back to us about what is hanging up on the PA or what the issue is, especially if you get to use a local one. And so I think that is a benefit to kind of finding a company that works very well with you. And so the PA process can look different here, but just kind of be careful as you approach it. So placing the order. So like we talked about with the hypoglycemia, you want to ensure the appropriate documentation is in the office visit. Don't just rely on the medication list. It's good to type it up in your note. So if the patient is insulin treated, you want to state that they're insulin treated, how many injections they're on per day, and why you think they would benefit, from a CGM. Doesn't have to be a long paragraph, but I think just a couple of one-liners about the difficulty, that they've had, or how many times a day they're testing their blood glucose, and why they would benefit from a CGM. And then if they are having hypoglycemia, so what that looks like, what problems that have arisen from that, how frequently, and what steps you've taken to mitigate the issue, especially if they're a Medicare patient. And then you want to order the necessary supplies. And so you can either do that by writing a prescription. And if they are commercial insurance, you can send that to the pharmacy like we talked about. Or if you want to print and fax the prescriptions to a medical supply company, if there's one the patient specifically wants to use, you can. I will warn you, they will likely send back a form similar to the one that is on this screen that they want you to fill out. It's a typical DME order form. Most companies have their own that they prefer. And then like at the bottom, they're going to request like demographics and office notes and where to send them. I included this as an example. This is a local one that we partner with very frequently, and kind of what these look like. And so it is very easy, I would say, to keep these on hand, especially if you have some that you use in specific communities, to go ahead and just fill these out and then scan them into the chart to keep on hand, rather than going through the trouble of writing it as a prescription and printing it, and then finding that on a printer and then having to fax it. So if you can kind of keep these on hand, or if you want to kind of build it into the EMR as like a quick text, you can do that as well and print it. Some of them, like this one, does have like an online portal that you can use called Parachute. So if you find those within your practice, you can set that up as well. And then if you do need help, of course, you can consult your clinical pharmacist here in clinic. We're always willing to help you fill out these forms and get that set up for your patient as well. But filling out these order forms are definitely the fastest way to get that done and to send those to the medical equipment companies. Sending them to the pharmacies kind of sometimes puts us in that cycle where it goes there and then they say it's not covered because it may not be covered under their pharmacy benefit, and then it may end up kind of dead ending there. So interpretation and analysis, developing a plan. So platforms to access data and reports. So the biggest ones that you will see are going to be LibreView and Dexcom Clarity, just because of the nature, like we talked about. If the patients are utilizing their smartphone device to scan and have accepted your invite to share, data should automatically upload directly to your online dashboard. You can even create shared practices and care teams, as well as determine which accounts have administrative rights. I would love to show examples, but so if you ever would like me to come to your clinic and kind of walk you through how to do that, I'm happy to set up local practices for everyone and kind of help work through that. If patients are utilizing their readers, they can choose to upload data to the LibreView or Dexcom portal from home to share, or what's more likely is they're going to bring it to clinic and have you do it for them. So they can bring that reader into clinic and you can take the cord and upload it to the respective platform for analysis. And then it'll upload and you can download that report for review. So this is an example that is taken straight from the ADA guidelines of kind of what the one pager of the first page of the ambulatory glucose profile looks like. And then kind of a definition of what each of the terms looks like. So the 10 things that you really want to look at on these reports. So the number of days that the CGM device is worn, you really want to recommend it's 14 days, just to give you time, I think, to look at all of the data. And then the percentage of the time the CGM device is active, you want to recommend at least 70% of data over 14 days. That may not always be possible, but that's kind of what's recommended. They're also going to give you a mean glucose. So that's over here, that's that average glucose. Your goal is less than 154. So that correlates to that A1C of less than 7%. Then you've got your glucose management indicator, which is similar to an A1C, so your goal is less than 7%. They used to call that an estimated like average A1C, but they changed the formula, I think, to make it a little closer to an A1C. And so they changed the name of it at that time. So that's why it's called the GMI now. Then you have your glucose variability. And so that's that percent right here. And so that's defined as that percent coefficient of variation. So sometimes you'll see that abbreviated like it is over here, that percent CV. And so that target is less than or equal to 36%. And then we get into the ones that I would say you are probably most familiar with, which is if you see these, which is going to be this bar right here, And so that's target, which is your time in range. And so your goal time in range is going to be greater than 70%. And then, excuse me. Then you've got your time above range, which is split into high and very high. And so the goal for all of this is to be less than 25%, with your very high being less than 5%. And then it's got goal for below range, time below range down here. So that's your level 1 and your level 2 hypoglycemia. And you want to minimize that as much as possible, but the goal overall is less than 4%. And then your very low being less than 1%, ideally 0. So I just kind of wanted to review those just a little bit. Obviously, it's going to show you kind of the summary here, with this being like your 25th to your 75th percentile, and then your daily glucose profiles, which shows you kind of how they've been every day. And this is if the patient has been wearing it and scanning it 100% of the time. So that just kind of gives you a brief overview. So this is an actual patient report. I did change the dates on it. So the dates are not what the actual patient's report dates were, but the data itself is accurate. And there are some issues I would say here that we'll kind of point out. I would ask them as questions, but I want to make sure that we get through all of this. And I don't know that we'll have time if I pause for audience responses. So a few things that you want to watch out for, especially when you're looking for this, is watching for the time frame. So if you were to pull this up today in clinic and you notice, and you didn't notice the time frame that the patient that you're pulling this for, so you want to make sure that, especially if they're using their smartphone or a reader, that it has been recently active. So making sure that it's pulling the most recent dates. So this is the last time it was active was April 4th or 24th. So you're missing a few weeks of data. So did the patient just not get sensors back in? Did they have trouble with their smartphone, or was there an issue getting the apps to sync together? So those are things that you might want to watch for, especially, now if you look at their phone and compare it to an online portal, and there's data there, you can still make those delineations. You also want to look at time that CGM is active. So if it's only been active 43% of the time, that may be significant for a couple of reasons. So do you have enough data to make an adjustment off of? Number one. Number two, do you have enough data to bill off of? Because that could also get you in trouble if you're trying to bill for this encounter, not just an E&M code, but if you're trying to bill for the CGM interpretation itself. And then also, are these statistics going to be correct if you're only looking at 43% of data? So that's where the rest of the report comes in handy, and why you don't just look at the summary data at the top. So based off of what we've got here, her GMI is not, the patient's GMI is not bad. The average glucose is 163, so it's a little above 7. And then your glucose variability is 40.1%. So we've got, I would say, a little more variability than we would like, even if our average is coming out pretty close to goal, even if it's above goal. And you can kind of see that. So our target, we are below 70% here, and we're above our goal of less than 25%. But we are still having some lows. So there is some variability within this. And you can kind of see there's a large gap where the patient did not wear it at all. But then there are also some daily gaps, which is concerning. And so this patient, I will tell you, was wearing a Freestyle Libre. And so if you're thinking about the Freestyle Libre, one of the pitfalls that we talked about with the Freestyle Libre that can occur is that data loss. And so if the patient is losing data throughout the day, that means that they're not scanning it at least once every 8 hours. And so while this may occur because of a sensor replacement issue, so maybe the patient didn't get their sensor in time if it was being mailed, or didn't have somebody to help them place it if they don't want to place it by themselves. Some of these other gaps are due to not scanning the device within 8 hours. And if that's happening frequently, you may need to provide some re-education, talk about, really reinforce that importance of scanning every 8 hours, and talk about what barriers they're facing and why that's happening. So with this patient, we're having lots of highs, it looks like, overnight. And so if you're really looking at that, you'd probably want to figure out when the patient is eating. So do they eat normal meal times? Are they eating or do they eat kind of later in the evening? Because you really want to figure out, is this, a pitfall of our basal insulin, or is this a pitfall of our mealtime insulin? And then kind of make adjustments based off of that. There are also other reports you can look at within our report. And so you can see this patient will check really frequently at sometimes, especially like after they've had a low, like she did this day, but then may not check at all during the day here, and indeed did not check again until this next day, which is why we lost several hours of data here. And so if a lot of those missing gaps are in the evening time, when on other days, they were having spikes, you may, it actually may have falsely lowered her numbers a little bit. And so that's also something to keep in mind, that her numbers may be falsely low, especially if she was missing several overnight days. And so just several things to keep in mind when you're interpreting these reports. I was going to spend a little bit more time on the patient case, but in the interest of getting to billing and reimbursement and leaving time for questions, we'll just kind of leave that summary there. But I do want to point out that if you go through the really detailed report, patients can, whether they use their reader or their smartphone, log when they take both their long-acting insulin, how many carbs they eat if they're counting carbs, and what dose of their rapid-acting insulin. I won't say all patients do it, but they can, and it is an option available to them. So if they do that, it does kind of make your job easier when you're assessing what happened and what kind of trend happened after they ate or after they took that dose. So that cause and effect relationship and how much data you have available. So billing and reimbursement. So the codes that you'll see used, and like I said before, you can build these with your E&M codes in clinic, are going to be these three codes that you see in front of you. So you've got your 95249 and your 95251. And I've got these out of order because those are the top ones are going to be the ones that you use in your personal CGM. And then that bottom one, that 95250, is for the professional CGM. So 95249 is a typically once in a lifetime code unless they switch between CGM devices. So you do have to have a minimum of 72 hours of data to build either one of those codes. And this is for patient provided equipment, sensor placement, hookup, calibration, monitoring, patient training, and printout of recording for the first one. And then for the 95251, it's for analysis, interpretation, and report. So with that first one, typically what you'll do is you'll have a visit where the patient comes in. You may help them place it for the first time, or they could have already placed it and paired it themselves. But you'll typically go through that education, show them how to read the report, and really go through the intricacies of what a CGM is, how we're going to manage it, and what that care looks like over time. And then once you get a minimum of 72 hours of data, you'll pull that report into the chart and you can build that first visit code. For the 95251, that's for analysis, interpretation, and report. And that actually does not require a face-to-face visit. And so you can see to the side that they actually have really good RVUs as well as reimbursement associated with them. And I pulled this from the Medicare fee schedule, and it's just based on national averages. For the 95250, it is a higher level of RVU because there's, I would say a lot more associated with that. And it's also covering for the cost of the device because you do not bill for the device separately. And so that's kind of where I would say the higher level of RVU and cost and all of that comes in. And so, like I said before, the 95249 can only be billed once per lifetime typically, but definitely once per lifetime of that device with the patient. 95251 can be billed a maximum of one time per month or is covered by payer. Typically, most payers will allow one time per month, especially if they are Medicare. However, there are some that may back it off and only allow it to be used a few times per year. And then 95250 is a max of once per month. However, most Medicare plans will not allow that to be billed monthly. That is just the maximum amount of times that you would be able to bill it within a month period. Typically, you could bill that a couple of times per year if it's allowed on their insurance. So documentation requirements. So if you are going to bill your analysis, interpretation, and report codes, typically you are going to want to document duration of time worn or time CGM is active, time in range, time above range, time below range, patterns of hypoglycemia, patterns of hyperglycemia, recommended changes to treatment plan, and then a copy of the CGM report. There are a couple of different ways you can do that. So you can print the CGM report and then just put like a sticker on it and have it uploaded into the chart. Another way that we do that is we will take a screenshot of the top part of the AGP, which kind of that ambulatory glucose profile, and copy that into our Epic notes. So I will copy that into kind of like my HPI. So like either my subjective or my objective section at the top, where I would normally include like a summarization of how their glucose is doing. And you can use snipping tool and it actually works very easy. And you just copy and paste that into their note. So usually, like I said, I'll copy this one and I'll copy that straight in. And then, this was another patient example I was going to do. So I normally would do that. And then I would just pick things that I would highlight off of this for my assessment and plan. So if I was going to assess, the time frame, that is something that I would, want to bring up. So the time the CGM was active, and then the gaps in which the patient maybe was not wearing the CGM. So, time CGM active. So if this was my assessment and plan, 63% over 14 days, reports difficulty placing sensors on her own and waits on her sister to visit or office visits for sensor placement. Also reports forgetting to scan sensor before bed. Time in range is at target and improved from previous. So that kind of gives you an assessment for not only where the patient is at today, but also the trend over time. Time above range at target. Hypoglycemia, 0%, less than 70 milligrams per deciliter. Nocturnal hypoglycemia not noted, and deny signs and symptoms. Because I would also want to ask, so are you experiencing signs and symptoms? Because sometimes our patients will treat signs and symptoms whether the numbers match that or not. And I will say, especially if you've had a patient that you've brought to goal rather quickly, that can be a common problem. So if you're starting to see them kind of have those hyperglycemic episodes, they could be over-treating like a hypoglycemia that does not exist. And then counsel patient to continue current regimen, discuss importance of not skipping insulin aspart if in range before meals, because that was a patient or that was a problem this patient was having, which was contributing to some of her hyperglycemia. If she was in range, she was a little nervous and started skipping her aspart. And so that's just kind of an example of how you would approach a documentation. Some resources that I think are very beneficial. There is a certificate program that is free through HbAIC. You don't have to complete the entire thing if you don't want to, because there are 9 modules, but I do think it's very helpful and it's free CME. And so they do go through many of the CGMs that are available, including ones that I did not cover today. And they go through interpretation of several different reports and patient cases. They go a little bit more in depth into the billing and some of the documentation. And they have kind of like a pre and post test to go through some more of those requirements. So if that's something you're interested in digging into more, that's the name of it. So it's called Putting Continuous Glucose Monitoring into Practice. And like I said, is a free certificate. You just have to sign up for an account through HbAIC and you can get that absolutely free. And so I see I already have some questions rolling in through the chat. Give me 1 second to review those and I will start answering. So if you bill a patient for a CGM, do they have a copay? So if you're talking about the device itself, that will be determined on an individual patient basis at the durable medical equipment place. If you're talking about for monitoring, that's again determined by the insurance. I have not pulled recently the percent of patients that have a copay for CGM monitoring. That is something that I would have to look into. It's been a while since I've looked at that, but that's definitely information that we could look into on a system level. How many patients have copays following continuous glucose monitoring, billing those 95249s and 95251s, but that's not information that I have available offhand. And then the next question is A1C still the standard for monitoring control of blood glucose levels, or are we transitioning to the valuable reports that CGM now make available? So currently A1C is still the standard for monitoring, especially on an insurance level. The guidelines, so like ADA and endocrinology, do allow for time in range within the guidelines. However, I would say that the A1C is still, I would say, considered maybe not gold standard, but it is still, I would say, the standard of practice. It's still kind of what we are most familiar with. It is what insurances are still going to require us to have in practice. And I would say it's still going to take a while before we are able to switch over to something like time in range in lieu of an A1C. Like, you're still going to have it on board, unfortunately. Are we able to prescribe CGM for diabetic patients on PO medications, i.e. sulfonylurea? So it would depend on the circumstances. If they have private insurance that allows it, so if they're on a commercial plan that allows for it, potentially, and if they're having problematic hypoglycemia, yes. So if they fall into that hypoglycemia category and they're not on insulin, you could, or if they have private insurance that allows for a CGM, and then you could. There were some Blue Cross Blue Shield plans that were private pay that allowed for CGMs. It just depended on the tier of their Blue Cross Blue Shield, what their copay was. So I had some patients that had copays of $0, and I had some patients that had copays all the way up to like $40 to $60. So it really depended. And then the second question was, we talked about Dexcom and Freestyle CGM. Do we also have prescribing privileges for the Medtronic CGM? Yes, so there's nothing that stops you from prescribing Medtronic CGM. I just really restricted this talk to, I would say, the most common ones that I see prescribed within our system. I really wanted to focus on specific ones to give recommendations on monitoring and prescribing for that today, because I knew I would have limited time.